Extreme patient movement during cataract surgery. Adapt and overcome. A common concern from patients undergoing eye surgery is, what if I move during surgery? Well, everyone moves during surgery. What do we normally do to compensate for patient movement? Number one, we give generous amounts of anesthetic on the eye and inside the eye to make our patients comfortable. Number two, patients receive a valium tablet that helps them relax. Number three, we ask our patients to look directly at the light in front of them to help them fixate on a target. Number four, I rest my hands on the patient's head so that when they move, my hands holding the surgical instruments move in sync with their head. Number five, our surgical instruments that we place in the eye actually help to mitigate eye movement during surgery. So everyone moves during surgery, but there are always outliers. The bell curve is real. This patient is an outlier. He has 4+ dense nuclear sclerotic cataracts. During his exam, he was able to fixate with this eye and remain still and follow instructions very easily. However, here we are about to start surgery and he is completely unable to maintain fixation or stability of his eye. As you can see, he's moving his eye in every direction, and despite our numerous requests for him to keep his eye still and look at our microscope light, or at least remotely look straight ahead, he is unable. He is awake and states that he's comfortable during his surgery. So, how do we adapt and overcome to this situation where the patient's eye is moving uncontrollably during surgery? There are a few choices we have. Number one, we could cancel the surgery at this point, then tell the patient that we need to perform his surgery under general anesthesia, and we would refer the patient to another ophthalmologist since we do not offer general anesthesia or IV sedation in our surgical center. Number two, we could simply refer him to another ophthalmologist who could operate on him. Or number three, we could adapt and overcome. So whenever situations go bad and conditions suck, it's an opportunity to get creative and get better. As they say, adversity does not build character, it reveals character. So let me walk you through this situation. So as you can see here, we're using 0.12 forceps to fixate the globe while we complete our capsulorhexis using the Utrata forceps. I'm using my left hand to fixate the globe and my right hand to perform the hydrodissection. And then I try to introduce the phacoemulsification tip into the eye, and then I realized it's really not safe for me to perform phacoemulsification on this patient's eye while fixating the globe with the 0.12 forceps. So I need to find a way to stabilize this patient's eye without using the 0.12 forceps. So we use a 5/0 gut suture to fixate the globe through the peripheral cornea. And I'm holding the 5/0 gut suture in my left hand and using a one-handed phacoemulsification technique where we essentially create a cross in the nucleus using a one-handed phacoemulsification technique. So I would say that it is important for surgeons to know how to perform one-handed phacoemulsification. Most surgeons use a second instrument and perform two-handed phacoemulsification. Well, for this case, I only have use of my right hand to perform the surgery. My left hand is holding the eye. Then we introduce an Inamura pre-chopper to fracture the lens into 4 quadrants. Throughout this procedure, we refill the eye with generous amounts of viscoelastic to protect the cornea. And using my right hand only, we're performing removal of the 4 nuclear quadrants. For irrigation and aspiration, I infuse the eye with viscoelastic to viscodilate the pupil, which reveals the cortex in the periphery of the capsular bag, which we're then able to remove with relative ease. This external view during surgery reveals how I am able to hold the globe using my left hand while using my right hand to perform irrigation and aspiration. The patient's head is also somewhat unstable, so you can see that the surgical technician is using both of their hands to stabilize the patient's head during surgery. An Li61AO monofocal lens is then inserted into the capsular bag, and the viscoelastic is then removed from within the eye. So the take-home points on this surgery are: if the patient is unable to maintain fixation, we can use a suture to fixate the globe, and it is important for surgeons to be able to perform phacoemulsification and irrigation and aspiration using a single hand. At the end of the case, the incisions are stromal hydrated and the eye is noted to be watertight. You can see without the suture to fixate the eye, the patient again begins to move his eye in a random set of directions. Fortunately, this patient did quite well. Their vision was excellent post-op day 1. And so I thought this is a great case to share how we adapt to challenging situations and adapt and overcome impediments in our way. Thank you for your time. Thank you for watching. Have a wonderful day, and I'll see you on the next video. Bye-bye.